Hello, everyone. My name is Olivia Jacquemart, and today we are going to be going through understanding and working with the IDD population. Please be aware that this is part 2 of 2, so everyone should be watching this video after the completion of part 1. First, we have to go through what our objectives are. So in part 2, we would like to review trauma-informed care implications to people with IDD, identify how treatment modalities may be adapted and considerations for people with IDD, and understand people with IDD and their unique needs, including sexuality. Here we are going to start looking at trauma-informed care, specifically when it comes to those individuals with an IDD diagnosis. First, looking at the prevalence of trauma, children with intellectual disabilities may be 3 to 6 times more likely to suffer abuse than neurotypical children. And then women with mild intellectual disabilities are about 5 times more likely to suffer sexual abuse than women without disabilities. So there is a high prevalence of possible trauma with those individuals who have an IDD diagnosis. And then not only are individuals with developmental disabilities more likely to be exposed to trauma, but exposure to trauma makes developmental delays more likely. So severe neglect can result in reduced brain size, density of neurons, and head circumference. We have a loop here that plays a part in one another. If one increases, the other is likely to increase as well. So it is really important to make sure that we are taking this into account when we are working with those individuals who have an IDD diagnosis. Due to the high incidence of abuse in individuals with intellectual disabilities, it is important that as mental health and DD service providers, that we, one, understand the concept of trauma-informed care, and two, create service environments that are sensitive to the needs of clients who have experienced trauma in their lives. But what is trauma-informed care? What do we mean when we say you should provide services with this approach? Well, trauma-informed care is an approach to engaging individuals with histories of trauma and recognizes the presence of trauma symptoms and acknowledges the role that trauma has played in their lives. So mental health professionals should also be aware of a highly trauma-informed initiative that has been underway within the DD sector for many years. This is called the Positive Culture Initiative. This initiative's goal is to bring out conversations about building collaboration within the DD system to create healthy relationships among and within organizations with the goal of improving the quality of life for people with developmental disabilities. Literally, it is about working positively together for the goal of benefiting our clients. So this means we should have community inclusion, which involves all people, regardless of their abilities or disabilities, and should be able to engage in various community activities. Community inclusion allows those with IDD to live life as a member of society while also being valued for their uniqueness and abilities. The goal is for those individuals with an IDD to participate, if they are able, in recreation activities, employment, housing, education, and peer support. A big trauma-informed approach that has been vital in providing support is gentle teaching. Gentle teaching recognizes the intrinsic relationship needs of human existence. A gentle teaching framework establishes a learning environment for teaching 4 pillars that mentor social emotional awareness and growth, validating the foundational human need for connection, companionship, and the longing for unconditional belonging or a sense of community. Those 4 pillars include 1, how to feel safe, 2, how to feel loved, 3, how to feel and be loving, and 4, how to be and become engaged or reciprocation. An example of implementing gentle teaching would be caregivers utilizing modeling by asking for a hug in an appropriate manner. The gentle touch of a caregiver may start to take on a new meaning of love and support from the opposite possible trauma from previous caregivers. IDD clients are often taught to be compliant, making them easy targets. They often have limited communication skills to facilitate the reporting of abuse, even on top of that. They may not have the language or ability to speak about the experience they have. And then resiliency supports, such as peer relationships, participation in extracurricular activities, and family supports, are often already minimal for clients with an IDD diagnosis. Due to this, clients may not be able to cope effectively and can turn to poor coping mechanisms and behaviors. Clinicians who believe talk therapy will not benefit clients with an IDD will be resistant to provide support, so clients will be left with only behavior modification interventions by the staff to problems they have developed in response to their trauma. Therapy for intellectual disabilities is more about than is more is about more than just improving skills or managing behaviors. It's about unlocking potential and fostering independence, improving an entire quality of life. It's about seeing the person behind the diagnosis and helping them write their own story of growth, resilience, and achievement. Here are some key differences between providing care using a trauma informed approach versus a non trauma informed approach. One of the biggest ones that is most often explained is the trauma informed, what happened to you, and the non trauma informed, what's wrong with you. So we want to be trauma informed here, especially when it comes to the caregiving and supporting. So down at the bottom there, you can see caregivers slash supporters with collaboration instead of rule enforcers and just trying to have compliance. So here we have some techniques for effective support. So our best practice and recommendations. First and foremost, your attitude is everything. If we are not positive and excited for our session, then the client's not going to be positive or excited about the session either. And then observe, figure out your client. What are their normal behaviors? What do they look like? And then we want to provide active listening to our clients, and we want to listen. We want to make sure that we are listening with our eyes and not just our ears. Then gather information. Get to know your collateral informants. Get to know who is at the house and who could assist you with obtaining that information. Then review all documentation. Get to know their treatment plan if you are not the one doing it. Get to know their assessment, their evaluation, and other care guides that could assist with their treatment. Then encourage your client and use those positive reinforcements. Again, your attitude is everything. And then we want to respond to challenging behaviors with empathy. So if you do have to respond to a challenging behavior, have a neutral facial expression and a controlled tone of voice that will encourage you to have empathy as well. And lastly, plan for success. A routine can be essential. So just know, respect, and implement that routine. And consistency and choice allows them to have control. We want to communicate in order to decrease boredom. And this here is just applied empathy. And this is how we can actively be empathetic with our clients. So this can be the number one way that we can combat any kind of challenging behavior, is just first and foremost having that empathy and making the choice to be empathetic. So first and foremost, it's all about staying out of judgment. Your client is receiving services for a reason, and you are there to assist them with that. Two, take another person's perspective. What if your loved one were in this situation instead of this client? Three, it's about recognizing the emotion. Recognize what emotion your client is having. And four, communicate that back. Communicate what you're observing and noticing within your clients. Then we have any kind of conflict resolution. So if you do have to provide any conflict resolution regarding those challenging behaviors, we have the best practice and recommendations here. So conflict resolution is of critical importance, and conflict between peers can lead to acts of bullying and violence. These 6 steps are excellent introduction to the conflict resolution, and this framework can and should be taught. So it's all about one, setting the stage, 2, gathering the perspectives of everyone involved, 3, finding the common interest, 4, creating options, 5, evaluating those options, and then 6, coming to an agreement. And next, we will get into the actual adaptation of BPBS services to those individuals with an IDD. Typically, clients with IDD are not self referred. Most come into treatment referred by someone else concerned about their maladaptive behavior, a parent, a caregiver, staff support, whoever it may be. They may not have any idea about what therapy or TBS psych is. They may not see the problem as an area of concern for them, or they may see the referral as a punishment or consequence of their behavior. Clients may feel that they have a lack of control, as they may not have any input into the choice of therapist or who will even be present with them during the appointment. The majority of clients with an IDD have many professionals involved in their care: case managers, rehabilitation providers, job coaches, behavior support specialists, and a variety of direct support professionals. Clients with an IDD may have no understanding of how your role is inherently different than all the other members of their team. Clients frequently experience the free sharing of personal information between this team and between all team members, and may have concerns that the information disclosed within sessions will be treated in the same manner. We often do need that collateral information from care providers, as clients with IDD are poor historians. However, at the same time, we absolutely need to keep confidentiality. So keep in mind, when speaking with individuals with intellectual disabilities, confidentiality still applies regardless of IDD diagnosis. We still need permission for collaboration and working with care providers. Care providers may often help when the client has very limited language skills, as they are more familiar with their speech patterns. And the care providers are also valuable in helping ensure that the treatment recommendations are followed and homework is completed. In the initial interview, throughout the initial sessions, we want to give a brief explanation to the client regarding what the meeting will be about and what services you can provide. Some simple examples you can give that must be tailored to the client's level of comprehension include: this meeting is a chance for us to talk about things that bother you. You can also talk about good things and things you like to do. Is that okay with you? And keep in mind, when speaking with individuals with intellectual disabilities, the client's level of intellectual functioning. Make sure that you are taking into account what your client can actually understand to give them the best chance to progress in treatment. We then want to know, what are the presenting symptoms? What symptoms are present that led to the referral of them? And then how do these symptoms compare to the client's previous level of functioning? Some more items that you need to keep in mind when you are examining and speaking to those with an IDD diagnosis: what types of stressors the client is facing. Are they experiencing familial, financial, or personal stress? How mental health symptoms interact with the behavior that is typical or atypical for the client? What skills the client has used to manage similar stressors in the past, whether those are maladaptive or appropriate coping skills? And then your own biases here. So, very important, be aware of your own biases about IDD and what impact they may have on the treatment process. Most clients with IDD experience receptive and expressive language limitations and may not be able to self report their symptoms. Establish that the cognitive deficit is legitimate and a neutral topic of discussion from the beginning. Normalize this for them. Know that they're not alone. That way, the issues regarding communication can be addressed openly. This is crucial when it comes to establishing the therapeutic alliance. Clients with an IDD may also struggle with the expression of emotions and feelings. This can be extremely debilitating, and they can feel overwhelmed and frightened by intense emotional responses that they do not understand. The ability to identify and label feelings provides a sense of control and comfort that can increase the client's capacity to appropriately manage their feelings. So, our goal is no longer to have our clients just react to whatever is going on in their body, but respond to it. How can they better respond to their feelings? We may need to interpret behavior for a client with IDD by identifying and labeling the emotions that are tied to the events discussed in the session. So, for example, you look sad when you talk about how sick your grandmother is. Other activities that can facilitate the labeling of feelings and emotions include the use of pictorial representation of faces to facilitate identification of emotions. It could be the use of journaling if they have the capacity, or the use of picture journaling as a substitute for writing. So, drawing pictures or putting pictures into a journal, as well as any expressions through music. Music can be a great way to assist our individuals in allowing them to communicate with us and how they're feeling. And then always ask the client to repeat back what they heard you say by introducing a checking back as a regular part of the process and session. Be praising of their efforts to feedback your communication. Remember, positivity within a session can make all the difference. And then check out your understanding of what was said to you, asking if you got it right. So remember Dr. Gentili that we talked about in part one? She will often use the phrase, "Can you fix it for me?" if she has not quite gotten what they are communicating to her. Remember, one of the aspects of applied empathy is communicating back what you recognize. By doing this step, you are being empathetic. Next, we will look into the adapting of specific modalities and interventions rather than just BPBS as a whole. First, we will look at DBT, or dialectical behavioral therapy. This was developed by Marsha Linehan in 1993 to address the needs of clients diagnosed with borderline personality disorder who are chronically suicidal and not benefiting from traditional treatment. The goal of DBT is to validate that the client's behaviors and reactions are understandable. This is without agreeing that they are the best or only approach to solve the problem. You're just validating that it's understandable. DBT focuses on helping clients learn to regulate their emotions and improve their ability to cope with stress and their interpersonal relationships. When looking at DBT for special populations, the main tenets of DBT remain unchanged. However, the presentation and language should be adjusted to a level that clients with an IDD diagnosis can more easily comprehend. We want the pared down concepts to allow for better comprehension and ability to apply the material. There's no use in applying the material if they can't understand it. So we want to make sure that we are adapting DBT and the main concepts of DBT in a language that is better suited for our clients. And then we have CBT, or cognitive behavioral therapy. Cognitive behavioral therapy is an effective treatment for depression, anxiety, and other psychological disorders. CBT can be adapted to help individuals with intellectual disabilities manage emotions, improve social skills, and develop problem solving strategies. It's like teaching someone to fish, but instead of fish, we're talking about life skills. And then adapted CBT with clients who have learning disabilities through the use of ABC, or functional behavioral assessment. ABC stands for antecedent, behavior, and consequence. So here we actually have the representation of ABC. So first we have the antecedent, whichever way you want to say it. That is the trigger. So what triggers this behavior? That behavior will then lead to a consequence. So you can see the arrows there, one leading into the other. So an example, and the antecedent is studying or relaxing and not studying for a test. And then the behavior is actually taking the test. The consequence, you fail or pass, depending on what you did before then. So it's common for people to just say, he started being aggressive for no reason. However, there's always going to be a lead up. There's never going to be a behavior without a very initial activating event. So what set off that behavior? And then the consequences. What is the payoff of the behavior? So some considerations. This slide introduces that FBA, or functional behavior assessment, which is a way to understand the function of the behavior. The goal is to figure out what purpose a behavior serves for the individual. In other words, what makes it rewarding for them. Remember, behavior is always a form of communication. That is so important. So, what is your client trying to communicate through this behavior? The big difference between understanding function of behavior and traditional interpretations of behavior is from what perspective the behavior is viewed. Direct support professionals and clinicians need to understand the behavior through the eyes of the person who engages in it, rather than talking about the problems it causes for other people. Most of the time, people talk about the behavior as inappropriate or inconvenient. For the person, it meets a need that he or she does not get in other ways. They're able to communicate through this behavior. So, this perspective is just helpful to maintain throughout the remainder of the section. The main points to learn here are one, direct support professionals and clinicians need to focus on an observable behavior, something they can see the person doing. And then two, there are basic elements that need to be understood and investigated in order to understand the behavior. This includes the antecedents. What are the antecedents? Are there any setting events? And what are the consequences? Behavior can meet the needs of a person and can make sense from the person's perspective. Direct support professionals and clinicians need to be able to identify what need the person is attempting to meet, and if the behavior is the most appropriate, effective way, the person can meet the need. So, it is a pattern of a behavior that repeats. We need to understand why that behavior occurs. And then this leads to, is the behavior. So just looking at the behavior as a whole. Is the behavior an attempt to communicate? Is it a way to avoid or obtain something? Or is it the result of a medical condition or other factor? Think about if someone is in pain or has a medical condition like a UTI. If someone's in pain, they may be acting out as a way to try to communicate that. If someone has a UTI, they could be having really disorganized or confused thinking patterns. Some other modalities to make sure you pay attention to can be one, group therapy. So, group therapy, you can learn and practice those coping skills. You're reinforcing working with others, and you're breaking down isolation. There could be mindfulness, taking time to actually focus on the intention of what you want your client to participate in. And well as the stop practice, getting into the DBT, dialectical behavioral therapy, and distress tolerance skills, learning how to tolerate when someone is in distress. We then have relaxation as well as that progressive muscle relaxation there, making sure our clients know that they can go through tense up, go through that progressive muscle relaxation, and then eventually go through and relax instead. And then next, we are going to be getting into our facial expressions. So psychologists have found that people's emotional changes are mainly transmitted through facial expressions. There are 6 universal emotions that are portrayed in facial expressions. This is one, anger, which is characterized by the eyebrows are down and together, your eyes are open wide, they're staring hard, and your mouth is rectangular or your lips are pressed tightly together. And then there's happiness. It is characterized by your eyes are narrowed with wrinkling around the eyes. There's crow's feet, some people call it. And then their cheeks are raised, as well as lips are pulled back, teeth are exposed in a smile oftentimes. And then there is sadness. This is characterized by the inner corners of eyebrows pulling up and together. It could be your upper eyelids are drooped, looking down, as well as your lip corners pulled down into a frown. And then there are surprise, which is characterized your eyebrows are raised but not drawn together like anger. Your upper eyelids are raised, but your lower eyelids are neutral. And then your jaw is slack or dropped down. There is then fear, which is characterized those eyebrows are raised and drawn together. Your upper eyelids are raised and your lower eyelids are tense. Your jaw is dropped, but your lips are stressed horizontally backward. It's not just dropped down. And then there's disgust. So this is characterized by lowered eyebrows, the wrinkling of the nose, and lips are raised, slightly protruding, looks like an inverted U. But why? Why are we learning about facial expressions? So we need to increase our own skills in this area before teaching clients. We as professionals need to develop our skills to recognize emotions in others, and we need to be aware of what our own facial expressions are communicating to decrease any kind of misunderstandings. It may be necessary for us to teach facial expression recognition to our clients if they struggle with expressing or interpreting emotions. The next few slides are for your own information and may inspire you to teach this skill to your clients. So here is our first picture here. What do you think is being portrayed? So we have a clear anger display. The eyebrows are drawn down and together, and this is an open rectangular mouth indicating less controlled anger. True anger is being portrayed here. What about this one? This is a more of a manufactured or fake anger expression. So the eyebrows are coming together more laterally versus together and down. And there's a peculiar activation of the chin, not typically associated with anger. The lips are rolling out and is more of an O shape instead of rectangular. So it's not really associated with anger itself. Number 3, we have an ingenuine or fake smile here. So notice that there's a flat action of the smile versus out and up, and there's a lack of that eye activation. Not a lot of wrinkles going on there. And number four, we have that true happiness. So if you look at the difference between the last one into this one, there is a stark contrast. There is more animation with the smile going all the way up and the obvious eye muscle activations there. Our next one. This is a manufactured expression, commonly referred to as a pout. So kind of fake sadness happening here, or a manipulation of the chin boss to elicit a desired response. Notice the absence of eyebrow activity and the abnormal retraction of the chin there. And then we have number 6. So this is sadness. However, it can be difficult to interpret the sincerity or intensity of display due to the signature being isolated in the mouth without retraction of the chin. There's no eyebrow display or action in the cheeks, which is apparent in the lack of any distinction of the nasolabial furrow. It's a borderline pout. However, it can still be difficult to determine. What do you think? We have number 7. Here we have that subtle, true sadness display. We have the chin going, retracting. We have the eyebrows furrowing. There is a more obvious definition of the face going on. We have number 8. Again, sadness and upset. We have 9. So this is more a suppressed or stressed variety of surprise. So we can see the eyes are quite large, the eyebrows are going up a little, the lips are tightened. Here's number 10 with that exaggerated surprise going on. Number 11, that is that true disgust. So we have the nose crinkling, the upper lip is raising, your eyes are closed. We have number 12, another true disgust going on. And then 13. So lastly, we have fear. The eyebrows up and drawn together. The mouth is stretched back. So those are our facial expressions. And lastly, just to reinforce some boundaries here and the sexuality that still applies to our clients with an IDD. People with IDD have sexual desires and rights just as everyone else. So some considerations for teaching about sexuality is the education and understanding. Make sure that you go about educating your clients in a way that is understandable for them. If they do not understand what you're saying, they're not going to have the proper considerations for sexuality. And then any potential risks. So the capacity to understand concept of choice, consent is huge. We need to make sure that our clients understand the concept of consent and bodily autonomy. And then there's biological age versus their mental age. How are they actually acting versus chronologically what their age is? And then the guardianship status of both parties. We need to understand that when our clients are not their own guardians, they are considered unable to give consent for themselves. So it's all about making sure that we are communicating and just understand that this is an aspect of our clients' lives. And then just beware of your own personal belief here. You shouldn't discount or just not talk about something because it makes you uncomfortable. So be aware and be understanding that this is a part of your client's lives, and understand the best way to go about setting boundaries in a professional manner to talk about it. And then it's all about advocacy and self advocacy. So the eugenics was a movement which originated in the 1920s that advocated to improve the genetic disposition of a population. During this time, people who were deemed to have what we would now consider to be an IDD, often labeled feeble minded or imbeciles in the past, would be sterilized. It was a practice that sought to improve the human race by reproducing only desirable traits. The most famous case was Buck versus Bell of 1927, where a 17-year-old Carrie Bell was deemed feeble minded. Psychologists and doctors tested Carrie's mother, Emma, and decided there was definitely something wrong with her and that her traits should never be passed along. Emma claimed not to know who Carrie's father was. Carrie, who had an illegitimate child as well, is also deemed loose and feeble minded by doctors, although they could not report what exactly was wrong with her. The jury and Supreme Court agreed that they should both be sterilized for the good of mankind. One juror, Oliver Wendell Holmes, said famously, 3 generations of imbeciles are enough. The people of this time truly believed that they were doing good by sterilizing people who were blind, mute, epileptic, or disabled in any other way. This is why advocacy and self advocacy skills are so important for our clients. They have the same rights as everyone else. People with IDD have sexual desires and rights just as everyone else do. So we just need to make sure that we are also aware sexual behaviors may also just be a form of communication. What we mean by this is that behaviors that appear to be sexual in nature may not always be. So some things that we may perceive to be sexual, such as stripping, it could actually be that they're having sensory issues. They're too hot or their clothes are itchy. It could be that they're exposing themselves when in reality they need to use the bathroom and can't find it. It could be that there's masturbation happening. Please understand the time and place and redirect. It is your client's right to be able to do that. However, this could just be out of boredom or frustration. There could be inappropriate touch happening, but your client just may not understand boundaries. There could be requests for hugs and kisses. There's an expressed need for physical contact. They may not know the appropriate physical contact. So, clients who have an IDD may need extra explanation or information repeated, such as with boundaries, especially about things such as why you can't be friends with them on Facebook, why you can't hug them, why you can't socialize with them, not be their boyfriend or girlfriend. And we want to maintain our balance as professionals. We definitely do not want that under involvement. We don't want to be cold and unfriendly, but we also do not want to cross the line and do not want to become friends with your client. We are paid supports. Friends are not paid supports. However, we are friendly people who help them and listen to them. As VPBS staff, we want to have a therapeutic relationship and be in this zone of helpfulness. Next up, we will get into some common boundaries that you should be implementing within your sessions and with your clients. First is that self disclosure of personal information. So, some self disclosure may be appropriate for some clients in some situations. Just make sure that you are being aware of what may be sensible and when. Best practice is to check with your supervisor first before disclosing personal information about yourself to a client. Then is keeping secrets. So make sure your client knows that you are a mandated reporter. You should not be keeping secrets for your client, especially when it comes to things like maladaptive behavior or coping skills. And then using nicknames or terms of endearment, that crosses a line and makes things confusing for what role you actually play for your client. And then social media. We should not have our clients on social media or vice versa. This is a HIPAA line is crossed, a HIPAA line is crossed. Can't think of the word right now, but we should not have anyone on social media that we are providing services to. And then gift giving or receiving. This same thing can cross a boundary and cross a line. If we give a gift one year and not the next, well, all of a sudden they're thinking, do they not like me anymore? Or if another client sees you giving a gift, well, do you not like me like you like them? It just opens a can of worms that you don't need to get into. And then borrowing, lending, buying, or selling. Don't do that to any of your clients. That is a side business. That is a conflict of interest. No need to do that. And then interpersonal spacing, otherwise known as proxemics. The best practice is to ask before getting in someone's personal space and avoid any physical contact as it can be misinterpreted. So, kind of both of those there. We always want to make sure any physical contact we do participate in is appropriate. So, things like fist bumps, handshakes, elbows, things of that nature. And then spirituality. So, your client may want to discuss their spiritual beliefs. However, it is usually not recommended to disclose your own, as it may make your client uncomfortable, especially if they differ. And then those dual relationships. So, what other kind of relationship may impact your therapeutic alliance? That can be really important to take into account and just make sure that there are no conflict of interest happening. That is all I have for you. So, just like with us before, if you have any questions or concerns, please do not hesitate to reach out to your supervisor for any further assistance and have a great day.